Hello and welcome back to the CNS Pharmacology Masterclass, where we talk about all the medications that work on the central nervous system. So now we will start discussing the sedative hypnotic drugs, starting with the barbiturates, which will be discussed in this video. So let's start with an overview. So the barbiturates are classified as sedative hypnotic drugs, and the sedative hypnotics also include the benzodiazepines, the zeta drugs, and the other hypnotics that we will discuss in later videos. And in comparison with other hypnotics, the barbiturates are dangerous because they may lead to respiratory depression and vasomotor depression. And the barbiturates are discovered in the early 1900s, starting with the ammobarbital, which was the first barbiturates to be discovered in the 1928, and it was used as intravenous anesthetic back then. This is a picture of the ammobarbital. Now let's explain what do we mean by sedative and hypnotic effects. So the sedative effect is when there is reduction in the central nervous system activity, leading to reduction in anxiety and exertion of a calming effect. On the other hand, we have the hypnotic effect, which is when there is reduction in the central nervous system activity even more than sedation, leading to drowsiness and sleep. And barbiturates can achieve both of these effects depending on the dose given. So when we give a certain dose, this might lead to sedation. If we increase the dose of the barbiturates, this might lead to hypnotic effect. So it is easier to think about it like that. So if we have this line, this vertical line, and it represents the CNS activity, so the higher the level here, the more CNS activity we have. And let's say that on this level here, we have the normal CNS activity. So this is what we call the normal CNS activity. If we increase the activity more, let's say at this point, we would get anxiety. So at this point, more CNS activity means anxiety. If we decrease the CNS activity less than normal, let's say here, we would get the sedation. So at this level, we have the sedation. And if we decrease it more, let's say at this level, we get the hypnosis. And if we decrease it more, we would get the general anesthesia. So let's say at this level, we would get the general anesthesia, and the lowest is coma and death. So the lowest CNS activity we have is the coma and death. And barbiturates can work as any of those at a certain levels. So if we give a little dose of the barbiturates, we would get an anxiolytic effect. So anxiolytic effect. If we increase the dose more, we will get sedative effect. If we increase it more, we get hypnotic effect. And if it becomes too high, we get the general anesthesia, and then we might get the coma and death. Now, why the barbiturates are dangerous drugs? So when we increase the dose of the barbiturates, there is more CNS depression eventually might lead to coma, as we mentioned. So when we increase the dose, first we get anxiolytic effects, then we get sedative effect, then hypnotic effect, and then we get general anesthesia and coma. And if we keep increasing the dose, this might lead to respiratory and vasomotor depression and death. And it is better to explain it like that. So if we have the horizontal axis is the dose, and the vertical axis is the effect of the barbiturates. So this is here the sedation, and this is here hypnosis, and this is here general anesthesia, and here is the coma and death. The barbiturates, when we increase the dose, it will go like that until death occurs. While the benzodiazepines, which is the other class of sedative hypnotic drugs, so this doesn't happen with the benzodiazepines. So with benzodiazepines, this doesn't occur. And that is why they are safer. So if we give benzodiazepines, with increasing the dose, they give the sedative effect and the hypnosis effect, and they reach the general anesthesia and they stop there. And that's why they are safer than the barbiturates. Now let's talk about the barbiturates classification according to the duration of action. So they are classified into ultra short acting, intermediate acting, and long acting. The ultra short acting example for them are the thiopental and the methohexital. Those have a duration of action of 30 minutes and a half-life of 8 to 10 hours. And it is important to mention here that the half-life doesn't necessarily have to be the same as the duration of action. And the barbiturates are example for that, because once the barbiturates are taken by the person, they would distribute first to the central nervous system where they have their action. But then they would redistribute into the fat and muscles, and that is when their action stops, and that is before their half-lives. For example, the thiopental and the methohexital, they have a 30-minute duration of action. So when you take them, first they would go into your brain for 30 minutes, and then they would redistribute into the fat and muscle, and they stay there for 8 to 10 hours. And that is why they have a T-half of 8 to 10 hours. Now the other class is the short acting. Those are example for them the hexobarbital, the pentobarbital, and the secobarbital. Those have a duration of action of 2 hours and a T-half of 10 to 40 hours. And the same applies for them. They first distribute to the brain, then they redistribute to the muscle and fat. Then we have the intermediate acting barbiturates. Example for them is the amobarbital and the butalbital. Those have a duration of action of 3 to 6 hours and a T-half of 15 to 50 hours. And the last class is the long-acting. Examples for them is the phenobarbital, which is the most used barbiturate nowadays, and the primidone. Those have a duration of action of 6 hours and a T-half of 80 to 120 hours. Now let's talk about the pharmacokinetics of the barbiturates. So starting with the absorption, the oral formulas of most of these medications are rapidly absorbed and the bioavailability is good. For example, the phenobarbital bioavailability is 90%. Regarding distribution, the barbiturates are highly lipid soluble and it distributes to most of the body tissues, including the brain. Then it rapidly redistributes to less vascular tissues like the muscle and fat, as we mentioned before, decreasing its concentrations in plasma and brain, and redistribution lead to termination of its central effects. So when it redistributes from the brain to the peripheral tissues, this would lead to termination of its effects. Barbiturates are metabolized by the liver, mainly by the oxidation process, by the CYP enzymes, and the excretion is renal. Now let's talk about the mechanism of action of the barbiturates. So the barbiturates work on the GABA A receptors in the central nervous system. And the GABA receptors are composed of 5 subunits like this picture here, and they are the chief inhibitory receptors in the CNS. And most of the other sedative hypnotic drugs like the benzodiazepines also work on the GABA receptors to reach their sedative hypnotic effects. And the GABA receptors are normally activated by the GABA neurotransmitters, which is the gamma aminobutyric acid. This neurotransmitter would bind into one of these receptors subunits to activate it. Activation of the GABA receptor leads to the opening of the ion channel that allows chloride ions to pass through it, leading to a reduction in neuronal excitability and inhibition of nerve transmission, which lead to CNS inhibition. So activation of the GABA lead to opening of the chloride ion channels, which allow chloride to pass through, leading to hyperpolarization and inhibition of nerve transmission. And the barbiturates cause enhancement of GABA. They also bind to the GABA and they cause enhancement of the GABA. So by interacting with the alpha and beta subunits of the GABA A receptor, which lead to increase the chloride ion flow, resulting in hyperpolarization and central nervous system depression. And most of the sedative hypnotic drugs work on the GABA also to increase the chloride flow, like the benzodiazepines and the Z drugs. Now let's talk about the pharmacologic effects of the barbiturates. So when the patient administers the barbiturates, this would lead to anti-anxiety effect at small doses and sedative and hypnotic effect in larger doses. This also might lead to an anesthetic effect with thiopental or methohexital. Those agents are the most to cause anesthetic effects of the barbiturates because those are given intravenously for a short period of time, so they would reach the brain in high concentrations, leading to the anesthetic effect. Barbiturates also lead to euphoric effect, which is a pleasant effect that occur when taking these medications, and that is why they are abused by some people. They also lead to anticonvulsant effect because they cause nerve transmission inhibition. They inhibit nervous transmission, so this would lead to anticonvulsant effect, especially the phenobarbital, which is used in treatment of tonic-clonic seizures. And they also lead to generalized CNS inhibition, including the medullary centers in toxic doses, leading to hypotension, bradycardia, and apnea. And the barbiturates induce the hepatic microsomal enzymes, the CYP enzymes. So this leads to the drugs that are metabolized by the CYP having lower levels because of the barbiturates effect on those enzymes. Now let's talk about the therapeutic uses of the barbiturates. So the phenobarbital is used in treatment of tonic-clonic seizures, and the phenobarbital also used as a hepatic microsomal enzyme inducer in the treatment of physiological jaundice in neonates. The thiopental is used in induction of anesthesia, but later it was replaced by propofol. So the thiopental and the methoxetal previously were used to induce anesthesia, but nowadays they are replaced by propofol, which have better anesthesia and lower side effect profile. The thiopental also used for interrogation because lying is more complex than telling the truth and it needs more CNS activity. The methoxetal is used for procedural anesthesia for cardioversion and fracture reduction. And the barbiturates was used for treatment of neonatal withdrawal syndrome, insomnia, and anxiety, but now mostly replaced by benzodiazepines and newer hypnotics because those are much more safer than the barbiturates. Now let's move on to talk about the adverse effects of the barbiturates. So starting with the tolerance. Tolerance means with a repetitive use of the barbiturates, this would lead to decrease in the effects that occur in the patient. So if the patient is repetitively taking these medications, the effect would reduce slowly and the patient have to increase the dose in order to achieve the same effect. That is what we mean by tolerance. They also lead to physical dependence. That means when we stop the barbiturates, this would lead to withdrawal symptoms. So the patient would have withdrawal symptoms in form of insomnia and anxiety when we interrupt the barbiturates suddenly. And both of these side effects are due to decrease the sensitivity of the GABA receptors and increase levels and receptor upregulation of the excitatory transmitters such as the NAMDA glutamate receptors. Barbiturates also lead to drowsiness and impaired concentration, and they also lead to hangover. Hangover means a state of psychomotor depression occurs in the following day after the use of the long-acting barbiturates like the phenobarbital, because the drug is still in the body, so this would lead to residual effects. There is also respiratory and myocardial depression, especially with the intravenous formulas and with higher doses. And there is increase in the porphyrin synthesis, precipitating symptoms of acute intermittent porphyria in susceptible people. And also, extravasation of the thiopental lead to severe tissue necrosis, which is treated with the topical application of local anesthetic and the local injection with lidocaine. So when the thiopental accidentally extravasate to the surrounding tissues, this would lead to tissue necrosis, which is treated with topical anesthetics. And hepatotoxicity, also a side effect that occur especially with the phenobarbital. Now let's talk about the drug interactions. So the phenobarbital is a strong cytochrome P450 inducer. It lowers the plasma levels of other anti-epileptic drugs like the lamotrigine, the phenytoin, and the valproate if the patient is taking them. And it also leads to contraceptive failure, so it leads to lowering the levels of the contraceptive pills in the circulation, and other drugs that are metabolized by the cytochrome P450 enzymes. Regarding the contraindications of the barbiturates, so they are contraindicated in severe respiratory insufficiency and sleep apnea syndrome because they have negative influence on the respiratory system. They also contraindicated in acute narrow-angle glaucoma because they increase the intraocular pressure, and they are contraindicated in pregnancy because they are teratogenic, and they are contraindicated with other central nervous system depressant drugs like alcohol because they would have synergistic effect leading to more CNS depression. Finally, let's talk about the toxicity with the barbiturates. So the barbiturates can be abused by people, as we mentioned, because they lead to euphoric effects, and overdose can occur from that, and the overdose can also occur unintentionally due to hepatic or renal problems. And acute barbiturate toxicity symptoms include CNS depression, respiratory failure, and hemodynamic instability. The treatment for the toxicity is with mechanical ventilation, intravenous fluids, and alkalinization of urine because those are acidic drugs. So the acidic drugs would be easily excreted when the urine is alkaline, and there is no antidote available for them. And with that, we reach the end of this video. Thank you guys for watching. I have a central nervous system pharmacology class that you can check out right now. It is free and it contains a valuable knowledge about all the medications that work on the central nervous system.